Assalamualaikum warahmatullahi wabarakatuh. My name is Muhammad Tauhid Ngah bin Abdul Amin. We are from Group 17. We would like to share and discuss about our topic, Universal Healthcare Access. Progress toward achieving universal healthcare and improving healthcare equity. And our research focus in Melaka, Johor and Negeri Sembilan. We would like to thank our lecturer, Dr. Nur Ajrun Khalid, SPA 502 Research Method course lecturer. So, I would like to share about our research context and sector overview. Okay, first, introduction to the topic. Universal healthcare access refers to ensuring that all Malaysians can access essential healthcare services of adequate quality without facing financial hardship. In Malaysia, UHA is largely delivered through a tax-funded public healthcare system complemented by targeted assistance programs for vulnerable groups. Why this issue is important? At the national level, UHA is critical for sustaining economic productivity, reducing inequality, and fulfilling Malaysia's commitment to SDG 3.8. Okay. SDG 3.8 focuses on achieving universal health coverage, meaning everyone gets the quality health services they need. Like, for example, like promotion, prevention, treatment, rehab, palliative care, without financial hardship, plus access to safe, effective, quality, and affordable essential medicines and vaccines. At the state level, it addresses disparities in healthcare access between urban and rural areas, as well as differences in service quality and capacity. At the societal level, equitable healthcare access protects low-income households from catastrophic health expenditure and improves overall population well-being. In short, healthy people, stable economy, less social tension. Linked to current development challenges in Malaysia. Malaysia faces rising non-communicable diseases, an aging population, post-COVID system strain, and persistent urban, rural, and public-private gaps in healthcare delivery. These challenges test the sustainability and equity of the existing health system, making universal healthcare access a central development issue rather than just a health policy concern. Malaysia's commitment to universal healthcare access is anchored in several core policy frameworks. The Health White Paper 2023 provides a long-term reform roadmap focusing on equity, system sustainability, primary healthcare strengthening, and governance reform. The 12th Malaysia Plan RMK 12 integrates health as a development priority, emphasizing underserved populations, workforce expansions, and reduction of out-of-pocket expenditure. At the operational level, initiatives such as PERCA B40, state-level health schemes, and the Telemedicine Blueprint 2022 address access, affordability, and service delivery gaps, particularly for low-income and rural populations. Together, these policies signal a shift from reactive sick care toward preventive, inclusive, and sustainable healthcare governance. Alignment between each area and government priorities. These studies focus on universal healthcare access and health equity directly aligns with the national priorities to reduce inequality, strengthen primary healthcare, and improve financial protection. Government reforms increasingly target equitable access, system resilience, and cost containment, which are core dimensions of UHA under SDG 3.8. By examining financing structures, service delivery gaps, and urban-rural disparities, this niche area supports the government's strategic objective of ensuring that healthcare access is based on need rather than ability to pay. In simple terms, the niche sits right at the intersection of health reform, social justice, and national development planning. Policy literacy and relevance. From a policy perspective, UHA is not treated as a standalone health initiative but as a cross-cutting development strategy linked to productivity, social stability, and fiscal sustainability. Current policies demonstrates an understanding of systemic challenges such as a public-private fragmentation, workforce maldistribution, and rising NCD burden, while proposing structural reforms rather than short-term fixes. This reflects mature policy thinking, moving from coverage on paper to access in reality and from fragmentation programs to integrate health system governance. In other words, the policy direction is clear. The real challenge lies in execution, coordination, and long-term political commitment. Next, we are moving to key findings from systematic literature review. Main themes and patterns in literature. The literature consistently portrays Malaysia as having strong de jure, means by law or by right, universal coverage through a tax-funded public health system with wide population and service coverage. A recurring theme is the tension between access and quality, where public services ensure affordability but face capacity constraint, while private care offers speed and choice at a higher cost. Studies also converge on the growing impact of non-communicable diseases, aging, and post-COVID pressures, highlighting a shift from acute care success to chronic care challenges. Next, key debates, gaps, and unresolved issues. A major debate concerns whether Malaysia should retain a pure tax-funded model or a transition toward hybrid financing or national health insurance to improve sustainability. Scholars disagree on the role of the private sector, whether it should be better integrated into public purchasing or remain market-driven. Another unresolved issue is whether current reforms genuinely reduce inequality or merely distribute pressure within an already overstretched public system. What existing studies fail to address sufficiently? Many studies focus heavily on policy intent and system design, but give limited attention to implementation capacity, governance, accountability, and political feasibility. There is insufficient analysis on how frontline realities, waiting times, workforce burnout, and regional service gaps translate policy promises into life experience. Comparative studies often cite international best practices, yet underexplore why successful models may face resistance or adaptation challenges in Malaysia's institutional context. The literature explains explains what should be done, but is weaker on how and under what constraints it can actually happen. Next, I will pass to my groupmate, Miss Adila.
Research gap and transition to empirical study, unanswered gap in policy and literature. The sub-extensive policy framework and academic discussion, a critical gap remains between formal policy commitment and actual experiences of healthcare access on the ground. Existing literature largely evaluate UHA through system-level indicator but pay insufficient attention to how these policies are perceived, experienced and navigated by users and frontline stakeholders. As a result, the question of whether UHA in Malaysia is equitable in practices, not just universal in principle, remain inadequate answer. In short, policies say access for all, literature measure coverage, but liberality is still a blind spot. Why empirical data is necessary? Empirical data is required to move beyond assumption and normative claims towards evidence and real-world outcome. Administrative data and policy documents cannot fully capture issues such as service accessibility, perceived affordability, waiting time or trust in public healthcare institutions. Primary data allow the study to assess whether policy objective translates into meaningful access, especially across income group, location and service types. Without empirical evidence, the discussion of UHA risks remain abstract, optimist and disconnect from implementation realities. How this gap shape research design and questionnaire? This unresolved gap directly informed the design of this research with adopt a user and system-facing perspective rather than a purely policy-centric one. The questionnaire was developed to capture prescription of access, affordability and service quality, and system responsiveness, align empirical indicator with the core dimension of UHA. By grounding the analysis in primary data, the study bridged the divide between policy intent, academic theory and practical outcome, enable a more credible assessment of equity and effectiveness. In a sense, the research design responds to a simple but critical question: does UHA in Malaysia work in intent for those who usually actually use it? Overall research objective. The overall objective of this study is to assess the extent of healthcare access and equity within Malaysia public healthcare system at the sub-national level. Specifically, the research aimed to evaluate accessibility, affordability, service quality, system capacity and the role of digital health based on users' lived experience rather than policy assumption. By using primary survey data, the study seeks to determine whether UHA is functioning equitable in practices, not merely existing as a policy commitment. Target population and state cluster. The target population consists of adult residents who have experience using public healthcare services in Melaka, Johor and Negeri Sembilan. These three states are from Southern Peninsula Cluster, representing a mix of urban, semi-urban and rural setting with varying healthcare infrastructure and population density. This clustering allows for comparative insight into regional differences in healthcare access and equity within a relative integrated socio-economic context. Key variables studied: accessibility, affordability and financial protection, quality of healthcare services, healthcare capacity and management, and also digital health utilization. Socio-demographic variables such as income group B40, M40 and T20, area of resident and urban rural location, are used to examine distributional equity and variation in experience. Variable and operational definition. The core variable of this study is healthcare access and equity, operationalized through measurable prescription-based indicator, accessibility, affordability, quality of care, healthcare capacity and management, and also digital health access. Each variable is translated into linked scale item to enable quantification of lived experience. How literature and policy inform item construction. Item construction was guided by established dimension of UHA in the literature, particularly access, affordability, quality and equity. National policy document including the Health White Paper and RMK12 inform the inclusion of system sustainability, financial protection and digital health component. Rather than measuring policy intent, items were designed to reflect implementation outcome, align theoretical concept with practical user experience. These ensure conceptual validity while maintaining policy relevance. Example questionnaire item. I am able to access government clinic or hospital when I need medical treatment. Digital health services such as MySejahtera or telemedicine make it easier for me to access healthcare. This item directly map abstract policy goal onto observable respondent level prescription.
I will explain my part for sampling strategy and data collection. Number one is about the target population. The target population comprise adult residents of the Melaka, Johor and Negeri Sembilan who have experience using the public healthcare service. This group is directly relevant to assessing the healthcare access and equality from user perspective. Number two is inclusion and exclusion criteria. Inclusion criteria include the respondent age 18 and above who have been previously exceed the government clinic or hospital in the selected state. Individual without any experience using public healthcare service and those below 18 years old will include to ensure that data relevant and technical compliance. Number three is about the sampling method. A non-probability convenient sampling approach was employed using the voluntary participation. This method is suitable for an exploratory across the sectional study with the limited resource and a focus on the participation based on an assessment rather than population level generation. Number four is about the data collection mode. Data we collected using a self-administration online questionnaire contribute in a via Google form. This approach ensures easy for access, anonymity, and minimal respondent burden. Number five is about the opportunities and economic consideration. The sampling strategy is appropriate as it targeted individuals with the direct experience of the phenomena under study and ensuring the content validity. Ethnicality, the method respect the voluntary participation, inform the consist and the respondent anonymity while minimizing risk and instruction. Through the sample size limit generalizability, it is sacrificed for identifying patterns, perception, and implementation gap, which aligns with the study and exploratory objective. We go to the part number two is about the technical consideration and concern. Number one is about the key economic risk. The study involved minimal technical risk as is collected non-sensitivity perception-based data. Potential risks include the respondent confirmed while reflecting on negative healthcare experience and unattended disclosure of personal view. Number 2 is about the conservativity and anonymity. Confidentiality is protected by not collecting personal identifiable information such as name, IC numbers, or contact detail. Responses are recorded anonymously via Google Form and used strictly for academic purposes only, with access limited to the research team. Number 3 is about the information consent. Consent is obtained through the clearly introduction statement that the beginning of the questionnaire outlining the study purpose. Voluntary nature is participate and the right to withdraw at any time. Proceeding with the questionnaire contribute imply the consent consistent with the technical standard for the low-risk social research. Number 4 is about the justification of the including vulnerable group. Vulnerable group including the minors and individuals unable to provide the informed consent are excluded to the avoid technical compliance and the power imbalance. This exclusion ensures that the participation is fully voluntary, informed, and free from the curation, while keeping the study within minimal risk technical boundaries. Number 3 is about the pilot test and instrument improvement. First thing is about the purpose of the pilot test. The pilot test is conducted to assess the charity, reliability, and usability for the questionnaire before full analysis. It is help identify ambiguous wording, confusing responses scales, and items that not effectively capture in the intended construction of the healthcare access and equality. Number 2 is about the planning sample size. A minimum of 30 respondents is used for the pilot test, consists with the methodological guideline for the preliminary reliability assessment in the qualitative survey research. This sample size is sacrificed and detected problematic item, test internal consistency, and ensure the questionnaire function and intended as a reflect in the attachment questionnaire design. Number 3 is about the reliability and validity check. Reliability is assessment through the internal consistency, examining whether item measuring the same construct, for example, accessibility or affordability, produce the assessment responses. Contact validity is ensured by aligning item with the established literature on the university healthcare access and relevant national policy framework to ensure each item reflects on the theoretical and policy-grounded concept. Based on the validity, evaluate by reviewing whether items are clearly understood and interpreted and intended by the pilot respondent. Number 4 is about the instrument improvement process. Items showing that weakness consistency, unclear wording, or overlapping meaning would be received for the charity or removed to the improve overall instrument quality. Feedback from the pilot respondent is used for simplify language, refine verification, and ensure each item contribute meaningful to the management objective. The final instrument retain only items that concentrate conceptual relevant and acceptable reliability.
Assalamualaikum warahmatullahi wabarakatuh and good evening, ladies and gentlemen. First of all, I would like to introduce myself. My name is Abdul Wasif bin Ahmad Tuti. I'm a group member with Group 17. And for this opportunity, I would like to thank to Dr. Nur Ajlan Khalid, our supervisor, for giving us this opportunity to present our findings regarding assignment 1 and 2. As you can see on the slide, for my part, we will present a reflection, policy and research implications, and lastly, conclusion. As you can see on the slide, our assignment 1 strengthened assignment 2. Assignment 1 provided the conceptual and policy foundation that directly shaped the empirical design in assignment 2. Through the systematic review of policies and literature, assignment 1 clarified the key dimensions: universal healthcare access, accessibility, affordability, quality, and equity, which were then operationalized into measurable variables. Rather than treating the questionnaire as a standalone tool, assignment 2 became a continuation of policy analysis, translating abstract commitments into empirical indicators. So through these two assignments, what we learn, we can divide it into 3 things, which is policy-informed research, ethical decision-making, and translating theory into measurement. So we talk about policy-informed research, what we learned through these 2 assignments. This project demonstrated that strong research does not start with data collection, but with policy and problem understanding. Engaging with RMK12 and the Health White Paper ensured that the research questions and variables remain policy relevant, not academically detached. What we learned that empirical research gains legitimacy when it speaks the language of policy while remaining analytically independent. So next, what we learned. Ethical decision making. Ethical considerations were not treated as procedural compliance, but as design choices affecting sampling, consent, and data handling. Decisions such as excluding vulnerable groups and using anonymous self-administered surveys reflected a proportional approach to ethical risk. This reinforced the understanding that ethical research is about protecting participants while preserving data integrity. And also what we learn is translating theory into measurement. One of the key challenges was converting broad concepts like equity and access into a clear measurable questionnaire items. This process highlighted gap between theory and practice, requiring careful operational definition to avoid vague and misleading measures. The exercise strengthened our appreciation that measurement is not technically translation alone, but a theoretically judgment call. Now we move to policy and research implications. First, implication for government policy. Once collected, the finding can provide ground-level evidence on whether current healthcare policies translate into equitable access in practice. Empirical insights on waiting time, affordability, and digital health usage can support targeted policy adjustments, particularly for B40 households and underserved areas. This allows policymakers to move from bad reform narrative toward evidence-informed prioritization. Next one is implication for service delivery. At the service level, The result can highlight operational gaps such as capacity constraint, staff shortages, and uneven service experiences across states. Feedback on user experience and digital health utilization can inform service redesign, resource allocation, and frontline management improvements. In short, data from users can help align service delivery with actual demand rather than administrative assumptions. And we move to conclusion. What is the key contribution of the study? This study contributes by translating universal healthcare access from policy concept into measurable, user-based evidence at the state level. And why it matters? Because healthcare access is not defined by a policy coverage alone, but by how people actually experience the system in terms of access, affordability, quality, and capacity. And final takeaway message to us is universal healthcare in Malaysia exists in principle, but its success depends on equitable implementation and continuous evidence-based development. And that's all for our group. Thank you.